Welcome to AETCM, the Emergency Medicine Channel. Today, let us discuss one of the important hematological malignant condition, that is multiple myeloma. We know that in our body, in bone marrow, there are some cells called as plasma cells. They have a very important role in our immunity. They produce various immunoglobulin like IgG, IgM, IgA, IgD, IgE. These are immunoglobulins. They act against various infections or inflammations in our body. They have a major role in inflammation in our body. So they are produced by plasma cells. So multiple myeloma means monoclonal proliferation of these plasma cells. The numbers of these plasma cells are excessively produced. The numbers are increased in bone marrow, that is multiple myeloma. Plasma cells proliferate in bone marrow and it can lead to reduced production of all other cells, like it can produce anemia, it can produce thrombocytopenia, it can produce neutropenia, and it also produce extensive bone destruction. Since it is overproduced in bone marrow, it can produce bone destruction, osteolytic lesions, osteopenia, and ultimately in some patients they develop pathological fractures. So immunoglobulins have two pairs of polypeptide chains, one pair heavy chain, one pair light chain. Heavy chain, you can see here the structure of immunoglobulin. IgM, IgG, IgA, IgD, IgE all produced from one side, that is heavy chain, whereas one pair of light chain, they have Kappa and Lambda chains. So abnormal and excessive production of these plasma cells can produce multiple myeloma. Sometimes it can heavy chain disease, sometimes it can light chain disease. So they are basically classified into heavy chain disease and light chain diseases. Heavy chain disease, again it is subclassified as IgG paraproteinemia, IgA paraproteinemia, light chain only, and other D and E chain disorders. Light chain myeloma, up to 20% of the myeloma is characterized by only light chain in the serum without expression of the immunoglobulin heavy chain. So light chain disorder, only light chains are increased. They have a peculiarity that they have high incidence of renal failure than other types of multiple myelomas. Now, once we already know that it's a bone marrow problem. Bone marrow overproduces these plasma cells. That's why you can see lytic lesions in the bone. You can see here X-ray. Lateral view of X-ray is very, very important. So in that lateral view of X-ray, you can see multiple lytic lesions. So there will be tenderness on examinations. That's why most of the cases when we examine like hematological malignancy, we always check for tenderness in the sternum and tenderness in the skull. Tenderness can be due to bony lytic lesions, or in leukemia it is due to increased production of marrow cells in the bone marrow. So both are possible. So tender lesions over skull, clavicle, sternum, ribs. Fractures and collapse of the vertebra can be there. So patient can have paraparesis, quadriplegia, all these things. Bone lysis leads to hypercalcemia. That is very important. Any lytic lesion in the bone, whether it is a primary bone disease, secondary bone disease, so bone malignancy, or multiple myeloma, all produces hypercalcemia because of lytic lesion. So in malignancies, alkaline phosphatase is elevated, whereas in multiple myeloma, even with a lytic lesion, alkaline phosphatase are normal. So that is a major difference between multiple myeloma to other type of malignancy, bone malignancies. In bone metastasis or primary bone diseases, you can see lytic lesions and you can see elevated calcium and elevated alkaline phosphatase. Whereas in multiple myeloma, you can see lytic lesions, elevated calcium, but alkaline phosphatase is normal. Patient also can have lethargy, weakness, all these things due to anemia. It is mainly due to anemia, and altered behavior is mainly due to the hypercoagulable state of the blood which blocks the cerebral circulation. Renal failure is very, very classical in most of the multiple myeloma. Either it is due to light chain disease induced kidney involvement, or mainly it is due to or secondary to hypercalcemia. You can see almost all types of multiple myelomas can have a high calcium that can precipitate in the tubules, and it can produce block there and can produce renal failure. Bone marrow failure, again it can produce, you know that bone marrow produces RBCs, WBCs, platelets, and so many other normal immunoglobulins which participate in our immunity. But here in multiple myeloma, there will be monoclonal overproduction of these plasma cells. So only plasma cells are produced there, or the number of plasma cell production is very, very high in this condition. So RBC production is reduced, WBC production is reduced, platelet production is reduced, normal immunoglobulins also reduced. So RBC production reduced means patient can have anemia and related features. WBC production and immunoglobulin reduction produces reduced immunity and infection. Thrombocytopenia produces bleeding. And increased paraprotein produces hyperviscosity and thrombotic events. So thrombotic events are very, very common in multiple myeloma, and many other malignancies, hematological malignancies also. The viscosity of the blood increases because the number of cells produced in the bone marrow or blood is very, very high, but they are abnormal, but they produces hyperviscosity. Now, renal damage is very, very common in multiple myeloma. It is mainly due to hypercalcemia. Hypercalcemia is the major problem in multiple myeloma, but it also produced by hyperuricemia, recurrent infections and renal infection, kidney infection, pyelonephritis, and it can be also due to amyloidosis. Amyloidosis is one condition which is present in almost all types of chronic inflammation. Here also it can occur, but the pathology behind this amyloidosis is different from chronic inflammation. Neurological problem, many patients can have peripheral neuropathy, carpal tunnel syndrome, vertebral collapse can produce compressive myelopathy and paraplegia. Radiculopathy is very common because of infiltrates into the radicals or compression to the radicals. They have radicular pain. And you have other features like calcium elevation, renal insufficiency, anemia, bone disease also can be there. They are the main features of multiple myeloma. You can remember it with the acronym, that is CRAB: hypercalcemia, renal failure, anemia, bone lesions. So that is a classical picture you see in multiple myeloma, but these pictures also can also be seen in many other conditions. So they are not the only diagnostic criteria for multiple myeloma, but clinically we can easily identify multiple myeloma in a patient who is having early renal failure without any other cause, hypercalcemia, normal alkaline phosphatase, bone tenderness, severe anemia, thrombocytopenia. You can make a plausible diagnosis of multiple myeloma. Then there is a syndrome called as POEM syndrome or osteosclerotic myeloma. Here you have polyneuropathy, organomegaly like spleen, liver enlargement, endocrinopathy, monoclonal protein elevation, skin changes. So this is a type of multiple myeloma. Here also you can get lymph node enlargement, that is called as Castleman's disease. So there are different types of different varieties of coming under multiple myeloma or increased plasma cell disease. Monoclonal gammopathy of undetermined significance. They are not multiple myeloma, but they are related to multiple myeloma. Here there will be serum monoclonal protein, whether it is IgA, IgG, IgM, it is less than 3 gram per deciliter. It can be a precursor of multiple myeloma. Monoclonal gammopathy of unknown origin is diagnosed in patients who meet the following 3 criteria, that is serum monoclonal protein, clonal bone marrow plasma cells less than 10%, that is very important, absence of lytic lesions, anemia, hypercalcemia, renal failure that can be attributed to plasma cell proliferation. Some patients who is having MGUS have a risk of progression to multiple myeloma 1% per year. So they can be called as precursor of multiple myeloma. They have some features of multiple myeloma, but they don't have definitive features of multiple myeloma. So some of these patients can progress to multiple myeloma. Now we can see the lab investigation. Patients can have anemia, leukopenia, thrombocytopenia and elevated ESR. Previously we used to diagnose multiple myeloma only on the basis of elevated ESR above 100. But nowadays it is not like that. We have various other diagnostic modalities. But however, elevated ESR in a patient who is having hypercalcemia, very high elevation of ESR, should have a differential diagnosis of multiple myeloma always when we are treating this type of patients. Elevated serum calcium and normal alkaline phosphatase, that is very, very important. Due to the absence of osteoblastic activity, alkaline phosphatase is normal. Ionized calcium should be measured if the patient has a high serum calcium level but no symptoms of hypercalcemia. Elevation of serum calcium may be due to binding of monoclonal protein with the calcium. So sometimes falsely high or low calcium can be seen in patients who is having multiple myeloma. So always do a correction of calcium with the albumin level in the patient's blood. So corrected calcium are very, very important. But however, if you are seeing a multiple myeloma cases, if the patient is having perioral numbness, hand numbness, carpopedal spasm and all, we have to always think about calcium disorders. It can be sometimes hypercalcemia, it can be sometimes hypocalcemia. Again, ECG is very important. You have to see whether QT prolongation or QT reduction. All these things are very, very important. But commonly you see hypercalcemia in patients who is having multiple myeloma. That itself can produce various arrhythmias and seizures and all. Elevated serum uric acid. Uric acid will be high if the patient is having high cell turnover and patient is severely dehydrated. All type of hematological malignancies, you can see there will be some elevation of uric acid, especially patient is having leukemia, acute leukemia or acute lymphoma and multiple myeloma, where the bone marrow production is excessive. You can see high uric acid, and this high uric acid itself can produce renal failure. So that is also another problem for kidney involvement. Creatinine is always elevated in multiple myeloma because of various reasons. One is multiple myeloma can lead to myeloma kidney, that is amyloidosis can be there, or it can be due to hypercalcemia, or it can be due to hyperuricemia, or it can be due to infection. So there are various causes for renal failure in multiple myeloma. But most of the patients who is having multiple myeloma, you can see elevated creatinine in them. Beta 2 microglobulin is one investigation which can also be done in patients who is having multiple myeloma. You can see that it is elevated in multiple myeloma. Now another important preliminary investigation is AG reversal. You can see normally when you are doing LFT, albumin is always more than globulin. There are very few conditions where albumin is low, globulin is high. There are some conditions where you can see that globulin is high, albumin is normal. So here what happens is albumin is normal but globulin is high. Whereas in liver disease, chronic liver disease, you can see albumin is low because production of the albumin from the liver is reduced. So albumin is low, globulin is normal. Here what you are seeing is globulin is high, albumin is normal. So AG reversal is a classical finding you see in multiple myeloma. Globulin is always high, albumin is low. Whereas in a normal person, you can see albumin is elevated than globulin. Bence-Jones protein is once it was the major investigation in multiple myeloma. Nowadays we have various other investigations also in multiple myeloma. Bence-Jones protein can be asked for urine. So Bence-Jones proteinuria is very important in diagnosis of multiple myeloma in primary and secondary settings. But in a tertiary care center, Bence-Jones protein has got limited value. Chest X-ray, X-ray skull, X-ray ribs, all are very important because you can see lytic lesions. We have seen the previous X-rays, lateral view of X-rays, lateral view of skull is very, very important. You can see multiple lytic lesions. CT and MRI can be done. CT spine is very important or MRI spine is very important. You can get a lot of lesions in the spine. You can get paraplegia, compressive myelopathy, so many abnormalities can be there in multiple myeloma. FDG PET scan, that is very important. FDG PET is very important investigation in diagnosing extramedullary diseases outside the spine. So you can get spine involvement, you can see it in X-ray itself, you can do bone marrow and find out whether bone marrow is involved with multiple myeloma cells. But FDG PET can pick up the extramedullary involvement of this disease. Serum protein electrophoresis is one important investigation. You can see first chart is normal serum protein electrophoresis, but you can see the second chart, you can see alpha, beta and gamma tracing can be there. Here gamma tracing is very high, that indicates a monoclonal or M protein related to multiple myeloma. Like this, one of the bands will be very high in multiple myeloma. So here what you are seeing is a gamma protein is very high. You can call it as monoclonal protein production is more, or M protein is more. So that is serum protein electrophoresis. Other investigations, you can do bone marrow study. Bone marrow study in healthy person, bone marrow shows less than 5% of the plasma cells. But in patients with multiple myeloma, more than 10% of the cells will be plasma cells. So that is very important, and bone marrow study is very important in patients who is having multiple myeloma. You have to do cytogenetic analysis also, and Kappa Lambda ratio also be done. The normal Kappa Lambda ratio in bone marrow is 2:1. A ratio more than 4:1 or less than 1:2 considered as the definition of Kappa or Lambda monoclonal abnormality. CD138 strain can be identified in plasma cells and aid the accurate determination of percentage involved. So CD138 is very important to diagnose plasma cells in the bone marrow study. That can be done in cytogenetic bar immunohistochemistry studies. Other things are like immunophenotyping and FISH study that can pick up T11:14, T4:14, T6:14, T4:16, T14:20, deletion 17p30, deletion 1p32. These are various immunohistochemistry, immunophenotyping mechanisms. So these things can be done by an hematologist. So they can do all this investigation, they can make a diagnosis. As primary physicians, we always do bone marrow study and other types of tests. Now, to make a diagnosis of multiple myeloma, you can do clonal bone marrow plasma cells more than 10%, and next one is calcium elevation, renal insufficiency, anemia, bone abnormalities clinically, and more than 60% clonal plasma cells in bone marrow, and other things are like MRI may show focal lesions in the MRI scan. So these are the routine investigation we do in our routine practice. Specialized tests will be done by hematologist. Now, how do you manage this type of multiple myeloma in emergency room? Most important thing in emergency room is these patients can come with severe bone pain. They can have bone tenderness, rib fractures, breathing difficulty. Breathing difficulty is mainly due to the rib pain. So normally in other conditions, breathing difficulty can be due to pneumonia or COPD or pulmonary edema like that. But here the breathing difficulty is mainly due to rib pain or lesions in the spine. So they have some type of restrictive lung disease because they will not be able to take any deep breath. So in that condition, there is no point in giving oxygen or CPAP ventilation. Nothing is possible. Their only pain relieving medications are very important. That is a main problem in emergency room in multiple myeloma. The breathing difficulty in this type of conditions like lytic lesions in the bone, whether it is primary bone malignancy, secondary bone malignancy, metastatic lesion to the bone or multiple myeloma, these all are due to inflammatory lesions in the ribs, fractures in the ribs or inflammatory lesions in the vertebra. So here pain relieving medications are more important than giving oxygen or NIV ventilation or mechanical ventilation. So if you don't relieve the pain, whatever you start, patient will not be able to breathe with his lungs. So pain relief is very, very important. Analgesics can be given, morphine can be given, pethidine can be given, fentanyl can be given. Any drug which can reduce the pain, that will be very helpful. Hypercalcemia, you have to treat with hydration, IV fluids, normal saline has to be given. Along with normal saline, we have to give Lasix, bisphosphonate like alendronate, zoledronic acid can be given. Steroids should be given. If the patient does not improve, dialysis has to be done. Calcitonin can also be given. Subcutaneous calcitonin can be given. Hyperviscosity syndromes, you can give heparin or low molecular weight heparin, and plasmapheresis is very important because we have to remove the excessive antibodies produced in the body. Abnormal antibodies, they are not normal antibodies, excessive abnormal antibodies. Uric nephropathy, again fluids are very important, give fluids, then give febuxostat, that is very important. Febuxostat is a drug which can remove the uric acid from our body, so that is very, very important. Rasburicase is another drug which can be given in uric acid induced problem. Chemotherapy, we will discuss afterwards what are the drugs used in chemotherapy. In bone pains, radiotherapy can be done. Bone marrow transplantation also can be done by hematologist. Now, there are some drugs which are traditionally used in chemotherapy of multiple myeloma, that is lenalidomide, bortezomib, dexamethasone. This regimen is called as RVD or VRD regime. So bortezomib basically that is given as a first line therapy in combination with lenalidomide and dexamethasone, IV or subcutaneous, 1.3 milligram per meter square, days 1, 4, 8, 11, 22, 25, 29, 32, 48 days we have to give, and along with other drugs like lenalidomide and dexamethasone. Alternative drugs are given like that is daratumumab, that is an alternative for bortezomib. So this is a flow chart given for treatment. We will not go into the details of flow chart here. We can refer the flow chart afterwards. Drug doses are given here. Combination of 3 drug combinations: bortezomib, lenalidomide, dexamethasone combinations. Alternative regimes: daratumumab, lenalidomide, dexamethasone. So that is an alternative regime for the previous regime, but 3 drug regimes are given. Cycle length is 28 days. So we have discussed about one of the important condition, that is hematological condition, that is multiple myeloma. Patients with multiple myeloma can come to emergency room with various problems. The most important problem is a lytic lesion on the ribs or in the thoracic cage. They have difficulty in breathing, they have severe pain, so they have hypoxemia, type 1 respiratory failure or type 2 respiratory failure. Oxygen alone will not help here. You have to give pain relieving medications, otherwise the breathing part will not improve. Second problem, they can come with hypercalcemia. Hypercalcemia should be treated with fluids, Lasix, steroids and zoledronic acid. These are the normal treatment should be given. Some patients come with hyperuricemia. Febuxostat can be continued, but acute elevation of hyperuricemia you have to treat with rasburicase. Another important problem in multiple myeloma is severe infection. Infection can be due to abnormal immunoglobulins which do not have any proper function, or due to reduction in the normal WBC count. So infection should be treated properly. Other 2 important problems are patient can have severe anemia and severe renal failure. So anemia is due to the production of blood is compromised because of elevated production of abnormal cells. So anemia is there. Some patients can have hemolytic anemia also, and some patients can have thrombocytopenia. So these are the common complications of multiple myeloma in emergency room. Thank you.